Hi there, it's Matt here, and welcome back to the podcast, and welcome back to another AMA episode, Ask Me Anything episode. I am, as always, joined by the extraordinary, the first-rate, the marvelous, the outstanding, the world-class entity that is Dr. Eti Ben Simon. Eti, welcome back.
You're too kind, Matt.
Only truths. Okay, so I think we have had, once again, a lot of interest, a lot of questions, and I will just let you take the wheel and drive. Off you go.
Wonderful. Yeah, we have a great set of questions today. And the first question is about the major differences in sleep between men and women. Is it true that women require more sleep? And if so,
Mm.
why is that?
Ooh, great questions. So there are definitely some fascinating differences in sleep between males and females. Sleep, as everyone knows from this podcast, it's a fundamental physiological process. And your sleep is going to be shaped by various factors including age, lifestyle factors, environmental factors, things like temperature, and your genetics, for example, too. But an often overlooked influence is the biological factor of sex and the sex of an individual. And here, as is done in biology, I'll refer to that as male or female. So let me address whether or not females require more sleep than males. And I'll try to break it down into sort of big picture structures of sleep, such as sleep duration, sleep quality, and then we'll go into detail into the architecture of sleep. So, sleep duration, there have been lots of studies now showing that reliably, on average, females will sleep slightly longer than males. So, if you look across all of the data and you sort of collect it all together, and I think I last did a deep dive into this decade of work, probably about 8 or 9 months ago. So there may be a few papers that have come out recently. But when we bring at least middle-aged males and females, just to try to be representative, into the lab, and we allow them to express their full, true, innate sleep need, what we found is that females will usually get a mean total amount of sleep of right around about 7.8 hours each night, whereas males will get around about 7.7 hours. So it's modest. It's a range between 20 to 40 minutes if you look at the data, which is not trivial, but it's reliable and it's statistically significant. So that's duration. Females do sleep longer than males. Next, we can speak about sleep quality. And here it's also interesting. We found that females will typically have fewer wake episodes than males. They will be awake or have fewer awakenings throughout the night on average. They will have an average of about 1.5 wake instances per night compared to males who will have an average of about 1.7 awake instances per night. It probably translates to females experiencing about a 13% lower frequency of the number of awakenings throughout the night relative to males. So that's quantity and quality. Now let me dig into sleep architecture. And as you'll remember from this show, sleep architecture describes the structure and the pattern of your sleep. And that encompasses the various stages, such as REM sleep, rapid eye movement sleep, and also deep non-rapid eye movement sleep or non-REM sleep. And what we found, and I think there was probably the most recent paper I read, it was a great paper that came out in the Journal of Clinical Sleep Medicine. They found that females tend to have a higher percentage of deep non-REM sleep than males, and that's age matched across the lifespan. Although once we get into older age, things change a little bit more. It's not by much, though, in early adult life and middle adult life in terms of the deep sleep difference. I don't think it's catastrophically like whopping. It's around about, if you look at the studies, it's about 7.8% greater amount. So in other words, about 8% greater deep sleep. But what's interesting is that that greater amount of deep sleep in females isn't homogeneous across the night. You see that difference only in the first third of the night compared to males. But once you get to the second and the third components of sleep, the third third of the night of sleep, allow myself to introduce myself. Oh, Matthew, you get about the same deep sleep. So it's still modest, but it's reliable and it's statistically significant. Yes, there are differences in deep sleep, but let's not forget REM sleep. And REM sleep, as you'll remember, is associated with dreaming. It's associated with emotional regulation and also memory and creativity. REM sleep also differs between females and males. I'm not going to make any stereotypes as to better emotional regulation and better creativity here in one sex compared to another. But if REM sleep is an indication of that, here's what we found that females will have a more rapid onset of REM sleep relative to males. In other words, females will quickly call up on the menu of different sleep stages across the night. They will call up REM sleep earlier in the night. Now, again, it's not huge, it's by about 10 minutes. Why do they dive into and start consuming REM sleep earlier in the sleep cycle? We have lots of theories, but for time, I may not necessarily go into it, but it may be related to more of that aspect of emotional wellness and mental health wellness. Eti, I don't know, you are far more brilliant and genius in this area of sleep and mental health. Any thoughts also on when REM sleep arrives earlier in females, theories as to why that would be? And again, I don't think anyone has a hard, definitive answer, but what would your thoughts be on that?
Yeah, we don't really know specifically why, but there is indication that getting into REM sleep earlier is not necessarily a benefit. We see that people who suffer from depression or different sleep disorders tend to get REM sleep earlier. So it remains to be seen if that's something to be concerned about.
I think it's very interesting. We have seen that in literature where people with major depression, they do have REM sleep arriving earlier. So it may be an adaptive function, a benefit where females are trying to begin working on those emotional, affective, mental health components earlier. Or it may be some aspect of that, which is that on average, we do see a slight trend towards females suffering greater rates and likelihood of
Exactly.
depression and also anxiety too, which is an area that
Yeah, almost a
you're the
doubling.
world's. That's right. That's right. You are the world's expert on that. We also know, by the way, in terms of differences between males and females are almost twice as likely, if not more, to suffer from insomnia relative to males. However, males are almost twice as likely, if not more, to have sleep apnea or sleep disordered breathing. But keep this in mind. That does not mean, however, just because females are more likely to suffer from insomnia, it doesn't mean that many males do not have insomnia. They do. And equally, it doesn't mean that many women have sleep apnea, often undiagnosed and often untreated. So I think the sort of the conclusion here is that sleep needs do vary quite considerably and in quite a nuanced way based on biological sex, both in terms of sleep duration, so quantity, quality, sleep architecture, and the severity of sleep disorders and sleep disruption.
Do you want to touch a bit on why do we think these physiological changes in terms of increased slow wave amounts, for instance, in female versus male? Do we have any thoughts on why is that happening?
Yeah, I think it's a very interesting question. Why do you also have a greater demand for deep sleep early on in the night, which is what we just described? Some of that may be because the buildup of sleepiness across the day is greater in females relative to males. And when you have greater sleepiness buildup across the day, you typically have a greater response in the amount of deep sleep, especially in the first third of the night. The other aspect, which you are familiar with, Etty, is that, as I mentioned, female individuals will have significantly higher rates of anxiety. And you have elegantly discovered, you've been the first really to discover it, that deep sleep seems to help almost offer this anxiolytic, this anxiety quieting benefit to decrease and dissipate the accumulated anxiety that's built up across the day. And perhaps this is why we're seeing what we would call as a homeostatic response. In other words, the system understands the needs and it responds dynamically. That's sort of the homeostatic notion, to bring things back into balance the next morning in terms of net neutral anxiety. We know, I think it was maybe Shackleton, I can't remember, but they had published some evidence that women on average will generally take longer to fall asleep than men. Some of that has to do with higher levels of cognitive activity and thinking before bed and once you get into bed. There are also some hormonal fluctuations. We also know that women will suffer levels of anxiety disorders at rates far higher than men. I think if you look at the data, it can be 2 to 2.5 times the rates of anxiety disorders are observed in women than they are men. And we know that probably one of the principal reasons that most people can't fall asleep easily is because that Rolodex of anxiety and the stress, and then it triggers a cortisol release, which leads to racing thoughts, and you catastrophize, and everything feels twice as bad in the dark of night than the light
The
of day.
next
And at that
question
point, it's
is
tricky.
the fascinating topic of shift work. And shift work, about 10 million Americans are working in jobs that require them to be awake during the night, either some of the night or all of the night. And it's a kind of rather new, I would say, line of work. I don't think we had it before we had electricity. So it's very interesting to think about the impact of shift work on sleep. So the question goes, what are the potential health risks of changing shift schedules while still maintaining 8 hours of sleep? So, for instance, if an individual goes from the morning shift to the afternoon shift to the night shift, or whether they work the entire day, then switch to working the entire night, and vice versa.
Let me touch on cancer, because there is that literature, and I suspect some people who are doing shift work have heard hearsay about this. It's probably good for me to provide some scientific basis for this. What we have found is that shift work can increase the risk of cancer. There is some inconsistency in the data, but I would say that overall there is a clearer picture emerging. I also want to note that the relationship between shift work, and particularly night shift work, is specific to certain forms of cancer. And so far, it is only associational in nature. It's not necessarily causal. Perhaps the strongest evidence so far for individual types of cancer relates to breast cancer. Numerous studies now have demonstrated a very strong link between a very strong link, by the way. Link is a relationship and association. It's not necessarily causation, but it does mean that shift work is associated with significantly higher rates of breast cancer. And there was a study, I think it was a study actually I covered in my book a while back, demonstrating that individuals who were working the night shift had a 32% increased risk of breast cancer. And this association has been reported in nurses, it's been reported in flight attendants, and a number of other different occupations. And what they found was that I think I can't remember quite, I think it was maybe every 3 years or every 4 years of working a night shift, there was about a 3.3% increased risk of developing breast cancer. So you can imagine then it becomes this almost compounding interest on a loan, that the more years one works, the higher and the higher that risk of breast cancer develops. One of the other studies that has looked at cancer has also found an interesting link with skin cancer, of all things. And they found that night shift work was associated with over about a 40% increased risk of skin cancer. I should note that was selectively in women. I don't think they looked at men, but I can go back and check, maybe put it in the show notes. So for, oh gosh, it must be at least a decade now, I have been an avid, probably more like rabid consumer of protein shakes. But the hard thing, honestly, in the supplement space, if you really understand and do your diligence, is this critical thing called trust. It is very hard to find a brand that you can truly trust. That's when I came across the company Puri and the really impressive founder. Even though I'm sure it makes them less profit versus other quick and loose companies, Puri takes quality more seriously than any company I've ever seen before. They have so many offerings, gosh, protein powders galore, but lots of other additions. But that's what I was focusing on here. Why did I choose them? Well, it's really for four specific reasons. Number one, they are free from hormones. Number two, they are free from GMOs. Number three, they are free of any pesticides. And number four, and this is the critical confidence part, every single batch is third-party tested for over 200 harmful contaminants, things like heavy metals, etc. All you have to do if you are a neurotic nerd like me, you can even scan the QRI code on the back of the product to get the third-party independent laboratory test results. That's how much trust and confidence they place in their product. By the way, if you want a recommendation, go for the dark chocolate flavored protein powder. It's just exceptional. In fact, it's wonderfully addictive. I didn't just say that. Anyway, it delivers 21 grams of protein per serving. And for folks of my podcast right now, you can save 20%. So go over to puri.com/Matt Walker, and that is spelled PUORI.com, Matt Walker. So again, that is PUORI.com/Matt Walker, and you will get 20% off your product.
How does lack of sleep affect someone who's pregnant, both during pregnancy and after the baby is born? And
Okay.
people are also asking if being constantly woken up during pregnancy, does it serve to get the body used to the lack of sleep after the baby is born? So sort of uh,
Yeah.
practice makes perfect.
Yeah.
And the last part of the question is, why is prolactin released mostly during the night?
Gosh, some interesting questions there, particularly the second one, which is a theory that was or has been knocking around, and I'll get to it, which is, could this persistent awakening at night and this essentially what is persistent chronic sleep restriction serve as a way to train a brain, and particularly the brain of a mother or father, and help them with some of that? So I will get to that. That is an interesting theory that's been out there. But let me pull back. Firstly, the question, how does sleep affect both a woman during pregnancy and during the postnatal period? Pregnancy is, of course, it's a transformational experience, and it brings about some rather profound physiological, hormonal, and emotional changes. There is a very large literature now in the sleep science world that has demonstrated, perhaps unsurprisingly to the first part of the question, that sleep disturbances are common both during pregnancy and during that postnatal period. But what many people may not know is that there are various implications of that sleep disruption profile, not only for the mother, but also for the baby. I will try to walk through these in my mind and structure it in a way that's meaningful. I'll start with the effects of a lack of sleep during pregnancy, and then I'll come on to the postnatal period. Before I speak about the consequences, I'll start with what we've discovered regarding the reasons why we see sleep disturbances to begin with during pregnancy. So, why should a mother, as she is pregnant, how best can she understand the reasons as to why that sleep is so difficult? Some of them will be obvious, some not so obvious. I think there are probably at least three different reasons. The first is just the physical discomfort of the body's physical change in form and the obviousness of how that body change makes sleep such a challenge. The second concerns some quite potent hormonal changes. And then the third comes on to frequent urination. The issue of frequent urination can be perplexing to people. And it's not just a result, and perhaps if I were to say, when a woman is pregnant, why do you think that there would be more frequent urination, including at night? Perhaps the obvious answer would be, well, it's because of the increased bladder pressure caused by the growing fetus. But it also relates to some of those hormonal changes that I spoke about as the second of the three reasons. Obviously, the first, physical discomfort, the second, hormonal changes, the third, urination frequency. Those three things are the things that cause the most sleep disruption in pregnancy. And the issue of urination, or more frequent urination, I've always found quite fascinating. I remember back when I was at Queen's Medical Centre in the UK, back as a young man, just being so interested by how this can take place outside of that obvious physicality, the mechanical pressure of it. And there's probably at least 4 or 5 different reasons that increased urination frequency occurs during pregnancy. The first is that there is increased blood volume and therefore kidney activity. So during pregnancy, a woman's body will experience an increase in blood volume. And because that enhances certain aspects of kidney function, it can lead to more fluid being processed and directed towards the bladder. And therefore, that is one of the reasons why you get increased urination frequency. So I guess the crass analogy would be, it's a little bit like turning on the tap handle of the water supply, and that increases because of that change in blood volume, leading to changes in kidney function, which lead to more fluid being processed. The second relates to hormonal changes. And here, for the urination frequency part of the sleep disturbance story in pregnancy, and I'm going to keep trying to pull myself back to this, one of the hormones in particular is something called HCG, and this increases during pregnancy. It stands for human chorionic gonadotropin, and it's almost like recalibrating the bladder activity, and it will produce more frequent urination as a consequence as it increases in its activity. So, what would be a good analogy? It's probably a little bit like adjusting the thermostat in your home for heating and turning it to a lower threshold, meaning that the heat turns on more frequently because there has been a recalibration of the thermostat. And so, therefore, the heat will stay on longer because the temperature at which it is meant to start heating is now at a lower level. And in some ways, that's how HCG does its work to increase urination, particularly at night during pregnancy, which is that it resets that thermostatic threshold, as it were, in the bladder, and therefore promotes more switching on of urination frequency. That's probably a terrible analogy.
That's the hormone that is being detected by home pregnancy tests. So it starts being
Correct.
released, around week 6. And there are specific kits that can detect it. And that's how someone can know they're pregnant.
And that's in part why some of that urination frequency increase during pregnancy happens as one of the earliest features. A woman will start to notice that really quite early on because HGC is coming online quite early during the pregnancy phase. That's why it's used in part as a detection tool. The third, I think I said there's 4 or 5. The third is the increased pressure on the bladder, and that is back to the mechanical pressure. So much like the fetus acting like a balloon that's expanding and in a very confined space, and the bladder gets pushed, and therefore the bladder's capacity is pressed upon, as it were, and that necessitates more frequent bathroom visits throughout the night. Another aspect comes on to bladder control. Some of the hormonal changes that happen during pregnancy will change almost the physical elasticity, the stretching of the pelvic floor, and that stretching of the pelvic floor will weaken it. And so it's a little bit akin to stretching a piece of tissue and constantly pushing more and more force on it. And therefore, that stretch on the pelvic floor decreases overall bladder control. And therefore, that sense, oh my goodness, I think I need to go to the toilet again, will increase because there is a decrease in overall bladder control. And then finally is just a simple increase in the flow of urine. And urine production is upscaled during pregnancy. Why is it upscaled during pregnancy? Well, in part, it's a means of efficient elimination of waste. Why would urine need to be increased in its production? Well, because you're now waste excreting, not just for yourself, but yourself and your growing baby. So, mother and fetus need to have a cleansing of the waste material. And so, urine production is upscaled in proportional response to the needs of the combined two entities, two organisms.
You just have
So,
to ask your baby not to pee during the night. If you don't mind being a bit more considerate.
yeah, could you send that text message to my child, please, Dr. Walker? So there can be pregnancy related sleep disruptions, as I described. And I think this comes on to another part of the question, which is what does that mean for consequences? Does that have any consequences? Well, there are, of course, some immediate consequences of the sleep disruption for a mother who is pregnant, and also perhaps some effects that can last a little bit longer. One of the features that we do see is, of course, mood disorders during pregnancy. Sleep disturbances do contribute very understandably to certain changes in moods, and mood can be more dysregulated. Some people would describe that more of swings in moods. It can lead to irritability, and it can also lead to higher rates of depression. And there have been lots of studies out there. I think there's probably one of the pioneering studies was by Field and colleagues, gosh, back in mid 2000s maybe. And they found that sleep disturbances in pregnant women correlated with increased depressive symptoms. And specifically, I think about 73% of pregnant females with sleep problems had depression relative to pregnant women who did not have sleep problems. So, pregnant women who are suffering with their sleep are also those who seem to have a significantly higher risk of depression. And we think in part it could be a link, a causal link, because we know that there is causal evidence now linking a lack of sleep to depression. So that's one of the first consequences. So I've spoken about that there are sleep disruption issues during pregnancy, why those issues occur, and some of the mechanisms. And now we're speaking about maybe some of the consequences. We've spoken about depression. It's also interesting that sleep disruption during pregnancy, and the severity more specifically, because almost every woman is going to have trouble with sleep during pregnancy. But if you rate the severity of the sleep disruption during pregnancy, it has been associated, and again, this is not causal evidence, it's simply correlational, but it has been associated with an increased risk of prolonged labor and specific birth interventions. And what do I mean by that? I mean things like cesarean deliveries. And so there've been some work demonstrating that women with the most severe sleep disturbances relative to those with the least severe sleep disturbances during pregnancy are far more likely, I think they were actually twice as likely to have or require the need for cesarean delivery compared to those, as I said, with mild sleep disruption. Perhaps no surprise also is, and we've spoken about this a number of times on the show, when your sleep gets disrupted and it gets short, or your sleep is of low quality, your body isn't as good at regulating your blood sugar levels. In other words, your blood glucose levels. What we found is that sleep disturbance during pregnancy is linked to an elevated risk of what we call gestational diabetes. And the greater the severity of that sleep loss, the greater the risk of gestational diabetes during pregnancy. And I think there was findings that I think it was actually was it the field? It was another study that came a few years later, and I'm blanking. But what they were finding, I remember the numbers, but they were finding that pregnant women who were sleeping less than 5 hours of sleep, and I think it was somewhere around about 4 hours of sleep was the mean, had almost a five-fold greater risk of gestational diabetes relative to those who were sleeping more than 5 hours. And so, again, that is not causal evidence. That's simply categorical. We're bucketing individuals into those who have not good sleep as a consequence of pregnancy, very short sleep, and those who have not as short sleep. And those who had short sleep had over a five-fold, 5 times increased risk of developing gestational diabetes.
That's a huge risk.
And it's a huge, huge risk. Essentially, that would be like saying it's a 500% increased risk. 30% or 50% increased risk is significant, but five-fold risk. Again, that is simply associational, doesn't mean it's causal. So those are some of the immediate links regarding pregnancy. Let me now speak a little bit about the postnatal period of time. A partner for today's episode is AG1. I've been using AG1 for quite some time now, and just for the record, I buy it myself to stay away from any of those trappings of free product. AG1 has just released the new formulation, which is AG1 Next Gen. It's still one scoop once a day, but now comes with many upgraded probiotics, plus additional vitamins and minerals. I also explored their 4 human clinical trials to prove out their efficacy, with the data showing a marked boost in healthy gut bacteria. And that's the thing. I appreciate how AG1 keeps adapting to new scientific findings. They have made many formula changes over the years, and each new iteration keeps it at the cutting edge of this space. As I've mentioned, I began my AG1 journey over 4 years ago. Any company that holds their scientific rigor to the flames of clinical trials means a lot to me. So subscribe today to try the next gen of AG1. If you use the following link, you'll also get a free bottle of AGD 3K2, as well as an AG1 welcome kit and 5 of the upgraded AG1 travel packs with your first order. So make sure to check out drinkag1.com/Matt Walker. That's drinkag1.com/Matt Walker. Postnatal, by the way, refers to after birth, postnatally. And here we often see sleep disruption continuing. In part, that's because of the baby's erratic sleep schedule. It knows nothing about this wonderful thing called a circadian rhythm at that point. In the first couple of months of life, the circadian rhythm is not yet glued into the neural architecture of the brain. It usually starts to beat out its 24-hour rhythm, usually at around 6 months-ish, and things start to come online and things get better. So it's not just the erratic sleep of the baby, which of course then changes the sleep schedule of the mother. It changes the schedule of the feedings. We've also discovered that there are some other sleep concerns or issues, but just perhaps for time's sake, let me speak a little bit about the implications of the sleep impairment. Postpartum depression. As I said, there can be depression that occurs during pregnancy because of the disruption of sleep, but also because of the continued disruption of sleep, there can be postpartum depression. And there are very strong links there that females who postpartum who have insomnia are about twice as likely to be diagnosed with depression. There can also be, though, interestingly, some cognitive impairment, that the sleep deprivation that comes postnatally can affect issues such as memory function. And there can be what we call lapses in memory, where people can temporarily have problems accessing memories that they may remember later. So it's not as though the memory has disappeared. It's just that they've lost the accessibility to a nevertheless available memory that's there. So a difficulty in retrieving the IP address of the memory. And then, of course, attention is also reduced, and ability to focus, which can be a problem. And I suspect for pregnant women or women who have gone through pregnancy and the postpartum period, all of those sound probably very familiar. So that's, I think, the first question. The second question, Eti, was related to this theory of, was it that the frequent
Yeah,
waking up during the night
kind of
almost,
prepares you.
yeah, not like sleep training for a baby, but it's actually sleep training for the parent. Is that sort of was that the
Yeah,
second
yeah.
question?
Being woken up so frequently during pregnancy sort of prepares you to what's coming up.
Yeah. So it has been a theory, and it is a theory that has largely been debunked, that this popular, or it was once a popular notion, that the frequent awakenings that occur during pregnancy in some way serve a purpose of preparing a mother for the postnatal sleep deprivation that they will undergo. And it sounds logical, but if you search the literature, there is limited, if any, support for that theory. So sorry, but I have to debunk that myth.
Yeah, I think in general, we don't really find evidence of biology trying to minimize or ruin sleep in favor of any benefit that would come out of it, right? I don't think
No,
of
it's
any.
it's very rare indeed. One of the two circumstances I can mention in biology in which we see the brain deliberately depriving itself of sleep are, firstly, when an animal is forced to undergo conditions of starvation. At that point, it starts to selectively restrict sleep, not completely deprive it, but itself of sleep, but it will start to stay awake for longer. It will sleep less, i.e., sleep restriction. Why? Because there is a signal of starvation going to the brain, and the brain says, okay, I need more time to forage in a larger perimeter because my current perimeter is not providing me with food. And if I don't do something quickly, I'm going to die. And so, therefore, it's one of the very extreme circumstances where the brain, it won't completely deprive that organism of the sleep that it needs, but it will at least limit it. So that's, I suppose, a sort of a slightly diluted version of that. The other place we do see it in the extreme, total sleep deprivation, it seems, is in some species in which they are caring for their young. And a good demonstration of this is in killer whales. When a mother is ready to give birth to a new killer whale baby, it will leave the pod, the group of killer whales that it normally schools with, and it will go off to a different location. It will give birth to its young killer whale calf. And then that is the time of highest jeopardy for the young infant calf to be eaten and killed. And as a consequence, the mother will undergo long stretches of total sleep deprivation, keeping vigilant watch over her calf as they are making the trek back to the safety of the pod. So, those are two extreme circumstances where there is life preservation after there has been reproductive passing on of genes. You could argue from a purely ruthless biological perspective that success has been made in terms of passing on the genetic legacy. So now mother is perhaps more disposable in that ruthless biological way. And I don't wish to think like that, but you can argue maybe that's in part the reason that then evolution has said, well, normally sleep is non-negotiable, absolutely essential. But in this circumstance, it's perhaps even more important to keep the new birthed genetic legacy alive, and therefore the older guard in terms of genetic legacy can perhaps undergo sleep deprivation to protect that genetic legacy. So that's, gosh, I've completely drifted on. And I know there's a third part of the question, which I think I've forgotten a little. Oh, it's prolactin, wasn't it?
Prolactin.
Okay,
Yeah,
gosh.
I loved your Hunger Game version of evolution.
Oh, God, it
I
sounds.
totally agree, actually.
Ladies and gentlemen, welcome back to Dr. Doom and Gloom.
Dr. Doom
This
and Gloom.
is Matt Walker. So, let me come on to the last question, which relates to hormones and one hormone in particular. The body, of course, undergoes some really quite dramatic hormonal changes during pregnancy, and those changes hormonally, several of them actually, in fact, affect sleep. One of them, which is not prolactin, but I should probably mention, is something called progesterone. And progesterone can have a sedative effect on sleep. And we've spoken about this a little bit before on the topic of sleep and sex, I think. And its levels of progesterone decrease postpartum. And that decrease in a sleep promoting hormone, progesterone, we think may contribute to the sleep disturbances that I mentioned before that occur during the postpartum period. I will just mention that because I think it's important, because it does come on to what I skipped over before, where I was saying, well, I should not spend some time on the reasons why there's postpartum sleep problems. I'll just come on to the consequences, but there is one of the reasons, several. Okay, but let me come on to prolactin and the timing of prolactin release. Prolactin is essential for milk production. And as I am always telling everyone at the Sleep Center, much to their chagrin, just like on this podcast, we love words and we love to break them down to understand what they mean. Eti, prolactin?
Prolactin. So lactin, like lactate, is actually milk. So it's very easy to remember. Pro milk hormone helps with the milk production.
So prolactin, the enhanced production of milk. We see highest levels of prolactin release occurring during the night and during those early morning periods. The nighttime peak in prolactin is actually quite interesting. It's fascinating. And again, I remember learning about this back at Queen's Medical Center in the UK. There is an inverse relationship between prolactin and dopamine, it seems, within the context of the postnatal period, where dopamine will inhibit prolactin release, which is an aside that I don't know is very helpful. But coming back to the question, what we believe is that the nocturnal rise in prolactin promotes breastfeeding, which can be both beneficial for the mother and the baby. So the act of breastfeeding stimulates then more prolactin production, and that prolactin can also have a sleep promoting benefit. So prolactin, just like progesterone, does seem to have a sleep enhancing feature to it. And what we're saying is that it's produced increasingly at night. And when it's produced at night, when baby is waking up, which is when mother needs to try to get back to sleep as much, not only does the baby's feeding caused by the increased prolactin at night help the baby to feed throughout the night, but the increase in the prolactin at night can conversely help the mother and help the mother during this tough period try to get back to sleep because of the frequent awakenings that will occur. So in some ways, this is actually the opposite of what we've just discussed, Eti, which is here is
Evolution is
biology,
coming.
is trying to do the exact opposite of deprive a mother of sleep. It's just saying, my goodness, I know that we have to do this, and it is an essential part of developing the next generation. But my goodness, as part of this intricate dance of hormonal changes, I'm going to have a feedback bonus that not only does the prolactin help with the production of milk to feed the young infant at night, it's also going to help you, the mother, to try to get back to sleep. Gosh, biology is wonderful, isn't it? And sleep is just amazing.
Wonderful.
Gosh.
And occasionally kind.
And occasionally kind, unlike to a killer whale mother who is desperately sleep deprived.
Yeah.
Okay, time for some honesty. I've probably eaten more protein bars in my lifetime than I've actually blinked. They've been such a constant for me throughout my life. I recently found David protein bars, and it was my friend Dr. Peter Attia who raised awareness about David. He played a key role in the development of this really quite radical new protein bar. And just hearing it from Peter, knowing his standards, that's all I needed to at least consider making the switch. And then I read about the company. They are fantastic. The bars are built on a simple, groundbreaking concept: the fewest calories for the most amount of protein, period, ever. And each bar contains a wonderful 28 grams of protein at just 150 calories. They have 0 grams of sugar as well. That is the best protein to calorie ratio that has ever been seen in a protein bar. The taste, exceptional. I almost have to ration them. They're that good, because I could probably inhale about 10 of them in one go. Protein, of course, by the way, it's critical. It's not just for building and maintaining muscles. It's for managing metabolic health, helping you feel fuller for longer. And it's that unique ratio that I think makes David protein bars, just for me at least, the most satiating that I've also ever experienced. They are fantastic. They've got 6 incredible flavors. And here's a bonus: when you buy 4 cartons, you get a 5th entirely free. If protein bars are your thing, even if they're not your thing and you're considering them, just go on over to davidprotein.com/Matt Walker. That's davidprotein.com/Matt Walker. And you will get a wonderful experience in terms of that bonus. Okay, back to the show.
All right, so the next question is actually a topic we had a lot of interest in, and it goes back to what we discussed in the beginning, the difference between males and females in terms of sleep, but this time zooming in on sleep and female hormonal changes. Can you tell us a bit about how sleep changes during the menstrual cycle, and then the transition to menopause, the perimenopause period, and then the menopause period?
Okay, fantastic. And I will also answer the question about hormone replacement therapy a little bit, but I know it can have some controversy. So there are certainly very intricate, of course, and dynamic hormonal changes during a woman's menstrual cycle. And there are equally significant changes during menopause, and both of those will influence sleep. By understanding the interactions, we can try to see if we can think about what people should expect during each of those phases. So let me start with sleep and menstruation and the menstrual cycle. The menstrual cycle, just as background for anyone, on average, it's around about 28 days, but it varies from one individual to the next. It's characterized by fluctuations in hormone levels. And perhaps they're not the only two by any means, but 2 of the primary hormones that change are estrogen and progesterone. There are others, of course, as I said. And I'll take these sleep changes that happen during menstruation based on the different phases of menstruation. So I'll start with the follicular phase of menstruation. That happens between about 1 to 14 days of that 28-day cycle. And this phase starts on the first day of menstruation and continues until ovulation. At this time, estrogen levels rise during the follicular phase. And studies have shown that females tend to have an increase in REM sleep during the follicular phase relative to the luteal phase. And that increase is non-trivial. It can be up to 32% relative increase during the follicular phase relative to the luteal phase. So then let's come on to the luteal phase, and that's somewhere between 15 to 28 day mark. That's what happens post ovulation. And at that point, progesterone levels surge. And while progesterone can have a sedative effect, and that's what we've been finding quite consistently, some females do still, if you look at the data, it's not consistent. Some females will experience disruptions in their sleep. But if you look day by day, it seems to happen particularly in the later luteal phase. And in fact, I think there's some data that found that during that late luteal phase, there's up to 25, maybe it was 27% reduction in the amount of deep non-REM sleep during the luteal late phase compared to the follicular phase.
That's
So
quite a reduction.
it's really quite a reduction. So both a stark increase in REM sleep during the first 14 days, the follicular phase, relative to the luteal phase, but then during the luteal phase, you see this significant decline in deep non-REM sleep. Again, we're trying to understand what that means and cause consequence. Is it that those sleep changes are helping orchestrate those hormonal changes? I think that's probably less likely. Are the hormonal changes the drivers of the sleep changes that I've described? So in other words, rather than sleep changing hormones, are hormones changing sleep? I think it's probably more so the latter, hormones changing sleep. Oh, I should probably come on to heat regulation and sleep because we'll come back to it during menstruation. Core body temperature varies considerably during the menstrual cycle, and that is due in part to the hormonal fluctuations. And I will come back to that aspect of what we call hot flashes in menopause in just a little bit. But let me stick here with the menstrual cycle. The rise in progesterone that I described in the second half of that 28-day period, which is the luteal phase, it can cause about a 0.3 to 0.5 degrees Celsius increase in body temperature. Now, you may think, well, hang on a second. In the daytime, it can be X degrees Celsius, and at night, it drops by 10 or 15 degrees Celsius. 0.3 or 0.5, surely that's not much. Inside of your body, that is quite a large amount. The relative change there is non-trivial. And that change, that increase in body temperature in the luteal phase, the second half of the menstruation phase, caused by the rise in progesterone, can create feelings of warmth that will disrupt sleep and disrupt your ability to maintain sleep. As I've spoken about in the episode on temperature and many times before on this podcast, we need to cool down to fall asleep, and we need to stay cool to stay asleep. But yet, during the luteal phase, progesterone increasing, body temperature increasing, therefore sleep disruption can increase.
Maybe we can just add that in the follicular phase, it is when an egg is about to be released. So it's really the start of the cycle. And from what you're saying, basically the worst part of the sleep is at the later phases, right? Then when we lose a bit of deep sleep, and we also have the changes in temperature.
Correct. Yes. Thank you. So I was doing start, quote unquote, based on numeric day of cycle, day 1 through to 28. But you can also think of it as the point of ovulation that is the start. So yes, essentially in the luteal phase, that's when some of the sleep challenges will probably begin, or you will notice them more significantly. So post-ovulation, I suppose, is just a better temporal lock to think about this, and the changes in progesterone. Despite progesterone having potentially some sedative effects, and by the way that we've looked at that too is during sexual intimacy and during intercourse and during orgasm, post-orgasm, progesterone levels and in females, oxytocin levels can actually increase. And both of those seem to have a sedative effect. But here we're talking about changes in progesterone that are not across minutes or decaying across an hour or so. But here we're talking about them across days. And that could be a very different equation. So thank you to remind me of that. Okay, on to menopause. Let's start with how common sleep problems are in menopause. Well, whether you look at survey data, things like the survey done by the National Sleep Foundation in 2007, or if you look at scientific data ranging from community surveys to clinical studies of insomnia in these populations, or you look at larger retrospective or even prospective population-based studies of menopause symptoms, what you find is that somewhere between 30 to 40% of women will report sleep difficulties during that time period. Whether that number is actually significantly larger, it doesn't really matter, because what we know is that the burden is non-trivial. Imagine that 1 out of every 3 women that you pass on the street going through menopause is struggling with getting anything like a good, consistent night of sleep. It is an undeniable and it's a pressing issue. So why does it happen? What are the physiological reasons underlying sleep disruption in menopause? Currently, our understanding falls into 2 broad categories, although more are emerging, and these are not mutually exclusive. Both can be occurring and both are often occurring. The first is hormonal changes. The second is what we call hot flashes. Let's start with the hormonal changes. Estrogen and progesterone are 2 primary hormones that see significant fluctuations and changes during that menopause transition. Why is this interesting? Well, estrogen has been found to promote sleep by the enhancing effects on a neurotransmitter called serotonin. And serotonin helps regulate sleep. And with that drop in estrogen levels comes a sleep disturbance that can ensue because of the alteration of serotonin. Progesterone, on the other hand, is a hormone that actually has sedative properties, and its decline can also contribute to the sleep issues. So, for example, some studies have revealed that estrogen levels can drop as low as 40 picograms per milliliter during menopause, and that, to give you some frame of reference, is compared to levels ranging from somewhere between 120 and 350 picograms per milliliter during the menstrual cycle. So that is a significant drop that occurs in estrogen. Now, I mentioned that estrogen plays a role in sleep regulation by way of its effects on serotonin, but it also has another indirect pathway, and that is the role of estrogen in terms of regulating body temperature. And of course, as we've spoken about many times on this show, it is temperature that also helps regulate the sleep-wake cycle. So when you think about these 2 issues, that you have a drop in estrogen, which can drop serotonin and therefore make the promotion, the generation of this thing called sound sleep a challenge, together with the lack of progesterone and its nice sedating effects, no wonder it is hard for women going through menopause to initially fall asleep or even stay asleep and generate continuous, robust, and sound sleep. So that's the first domain of mechanism, which is hormones. The second underlying mechanism is hot flashes. These hot flashes are part of what we call the vasomotor symptoms of menopause, which is just a fancy combination set of words describing changes in the regulation of blood flow and blood vasculature. And it is that blood flow and the blood flow dynamics of the vasculature that regulate temperature both within and across the body. And when you look at the data, what we find is that up to 85% of menopausal women experience hot flashes, and somewhere between 40 to 60% of the women who do experience hot flashes report that these episodes are a major factor that markedly disrupts their sleep. Why does it disrupt their sleep? Well, for 2 reasons. First is that temperature, as we mentioned, is key to regulating sleep. And in our previous podcasts on sleep and temperature, you'll remember that I told you that we have to cool down and stay cool to fall asleep and then stay asleep. And when you're experiencing these hot flashes, almost if you want a reference point, like trying to sleep on a very hot night, it disrupts your ability both to either fall asleep or stay asleep. The second reason that hot flashes have a sleep consequence is night sweats. And they can result in a drenching sweat that accompanies the hot flashes at night. and that drenching sweat is sensed by the body, waking the brain up, and that can lead to additional sleep problems. And as I mentioned, so far what we found is that the declining levels of estrogen are directly linked to the frequency and the severity of those hot flashes, which in turn predicts the challenges with sleep, meaning that the drop in estrogen causes sleep punishment on two different levels. First, it affects sleep directly by estrogen's role in serotonin regulation of sleep, and then indirectly by way of these hot flashes causing awakenings and thermal dysregulation of sleep control. So far, you may have noticed that I've been using a generic term of sleep disruption or sleep disturbance in menopause. But let me get very specific about the different types of sleep disruption caused by menopause. There are essentially 4 types of sleep impairment that are associated with the transition. And not all women will experience all of these. Any one woman may experience one of these or some combination of the 4. And the 4 are as follows. The first is insomnia, characterized either by difficulty falling asleep, difficulty staying asleep, or waking up too early. Beyond insomnia, the second issue that we see in terms of sleep disruption is something called sleep disordered breathing, and specifically sleep apnea. Now again, on this series, I've done a whole entire podcast on sleep apnea, and that's where you get significant disruption of the airway, even closure of the airway. It causes snoring. It can cause you to stop breathing. It is really a devastating condition with non-trivial consequences. And what we've discovered is that the decline in estrogen levels can lead to the loss of the muscle tone in the upper airway that normally keeps your airway open as you're sleeping. And as a result, it can increase the risk of obstructive sleep apnea. And that's that condition where you get snoring or breathing stops temporarily and entirely during sleep. The third issue with sleep concerns restless leg syndrome. Now, this is a sleep disorder that I sound like a broken record, that I've also done an entire podcast on. You can listen to that if you want to learn more about it. But some women going through menopause, not all of them, but some will develop this condition called restless leg syndrome, which is an experience of very uncomfortable sensations in the legs, and it compels them to move. And as a consequence, that sensation interferes with your ability to either fall asleep or certainly to stay asleep. The fourth and final issue concerns specific sleep stages. Although modest in the number, there are several studies describing selective impairments in REM sleep caused by menopause. This in part may be due to the hot flashes, since REM sleep regulation, perhaps as much, if not more than even deep non-REM sleep, is very sensitive to temperature. And there's importance here. Considering the key role that REM sleep plays in regulating and rebalancing our emotions and our moods, these deficits in REM sleep caused by the hot flashes during menopause may be a contributing factor to the recognized emotional and mental health challenges that women face when they're going through this transition. So that's underlying mechanisms as well as sleep-specific consequences. Now let's turn to treatments, or I should really say attempts at management. The first approach is called hormone replacement therapy. Before I describe the data, let me say this. The topic of HRT in women, I know, can be a lightning rod issue. I don't have a horse in that race, and I respect everyone's opinion and their own choices. All I would offer on this issue is the following. My dear friend, Dr. Peter Attia, has spoken a lot about female hormone replacement therapy, and the data around that topic and any of the data regarding concerns about HRT on his podcast and also in his blog posts. And if you're interested, I would gently offer the suggestion of reading a post that he wrote, a blog post called Clearing the Air on HRT. Coming back to this podcast, coming back to sleep, we mentioned how deleterious the disruptions to estrogen and progesterone are caused by menopause in terms of their direct influence on sleep, as well as their indirect impacts. And so by rebalancing those hormones with hormone replacement therapy, what we often see are sleep improvements. And whilst there are some inconsistencies in the literature regarding the absolute efficacy of HRT in terms of sleep, the majority overall are very positive, and there are some great studies by incredible sleep researchers in my field, folks like Jackie Montplaisir, Rachel Member, Colin Espy, Susan Redline, and many, many others. And I'll describe the results not in terms of just what they found, but also across all of the studies. I'll try to give you a sense of what was found to be a big effect, what was a modest effect, and one that had some limited or at least equivocal data. And here there are 4 groups of findings regarding the impact of hormone replacement therapy on sleep disruption in menopause. The first are improvements in sleep quality. Numerous studies have consistently reported that HRT, hormone replacement therapy, improves sleep quality and improves it both subjectively, meaning that which the patients are actually telling the researchers, and objectively, meaning in sleep recording measures themselves. The second set of benefits is reduced nighttime awakenings. Hormone replacement therapy has consistently been shown to decrease the frequency of nighttime awakenings, and as a result, it improves the efficiency of sleep, the continuity of sleep. The third change concerns sleep architecture. A number of studies have indicated that HRT, and in particular estradiol, seems to solidify and improve the normal architecture of sleep, and as a result, that can lead to increases in the amount of deep sleep. The final component is on sleep apnea, or sleep disordered breathing, as I said. And here, at least to date, there seems to have been only a moderate effect of HRT on sleep apnea. Some studies have reported benefits to sleep apnea, and others did not. Considering that there may be some discussion or thoughts around HRT, what about other treatment approaches? Well, I'll start with medications. Again, for the record, I am not a medical doctor. I am not offering prescriptive medical advice, but rather descriptive scientific data. But the first approach has typically involved, in terms of medications, classic or current day sleeping pills. Things called the benzodiazepines or the Z drugs, and the Z drugs like Ambien, because its generic name is called Zolpidem, and lots of the other classic or current sleep medications begin with the Z, hence they're called the Z drugs. And there is some data showing that short-term treatment with these drugs, lasting somewhere between 2 to 4 weeks, can be effective at improving some of the sleep problems during menopause. For example, there have been studies with the drug Ambien showing that it can increase total sleep time and decrease the number of times that women wake up during the night during that menopausal period. However, and I've spoken a lot about these drugs, and I've also written about them in a wee little book that I wrote, these sleeping pills do typically have side effects. They can cause concerns for falls, and they need to be used very carefully. Also, modern day medicine only recommends these types of drugs to be used on a temporary, a short-term basis. So what else? Well, there is melatonin. And again, I've spoken a lot about melatonin on this show and some of the non-trivial concerns and limitations around melatonin, specifically around over-the-counter melatonin. That said, a select few small studies have shown melatonin to mildly improve sleep and also mood in women going through menopause. But I should note, by the way, that in those studies, they were using medically prescribed slow-release formulation of melatonin. That was not the over-the-counter melatonin for the concerns that I've mentioned above and previously elsewhere out in the public. Another medication approach that's been used is a drug called gabapentin. I spoke about gabapentin on this show during the episode on restless leg syndrome. And studies have found that somewhere doses between 300 to 900 milligrams can reduce the severity of the hot flashes. And some of those studies have demonstrated reductions by up to 60%. Just keep in mind that gabapentin can have some side effects like drowsiness, including during the day, so keep that in mind. Drugs aside, let me come on, however, to the strongest data and recommendation by sleep medicine, which is a non-drug therapy that we've also done podcasts on before called cognitive behavioral therapy for insomnia, or CBT-I. Anyone who is a regular listener to this show will have heard a lot about CBT-I and how it works. And here, the data are really quite robust. CBT-I improves sleep problems in women going through menopause. CBT-I, I should note, it's not a cure-all, but it is without side effects, unlike many of these medications, and it has good scientific justification. So there you have it, a short overview of sleep and menopause. Bottom line, society needs to recognize the very real impact of menopause, including the sleep disruption. And we need to find better ways to support women, and that includes both doctor and patient education regarding these sleep problems. Also about the administration of the right treatments for these sleep problems, and even improving and enhancing a greater workplace understanding of the challenges of menopause. So, with that, I will close out this round of our AMA. Eti, thank you again so much for your co-piloting, your brilliance, and your insights. You are always wonderful. And for everyone listening out there, thanks for tuning in. If you are enjoying it, please just share the podcast with friends. Spread the sleep knowledge, be a sleep ambassador. And for now, I will simply say good night, take care, and we will see you in the next episode. Bye for now.